one of the Dr. Amani Shahri. This webinar will be almost 1 hour, and we are hoping that
Good evening, everyone, and welcome to our webinar. My name is Hajar Al-Dahim. I'm clinical pharmacist and work as an advisor to the Assistant Deputy Minister for Therapeutic Supportive Services at Ministry of Health and the Director of Drug Policy and Regulation Division. Our webinar today will provide you with an update on clinical considerations for COVID-19 in patients with MS with Dr. Malik and Dr. Jama. We also have the pleasure of having Dr. Tarabolsi joining us from Canada to provide us with an update on MS and NMO therapies, along with Dr. Amani Shahri, our clinical pharmacist, to share some regional insights and experience of these medications. This webinar is kicking off our MS educational program series that is focused on providing you with the current relevant information and specifically designed to meet the needs of MS clinicians, pharmacists, and all healthcare providers in Saudi Arabia. This educational series is a collaboration with Ministry of Health Saudi Arabia, Roche Pharmaceutical, and MD Briefcase. Thank you so much for joining.
Thank you, Dr. Hajar, and I'd like to welcome you all, and good evening for you, and thank you very much for joining us on Friday evening. I'm hoping that today will be a very well educational program for you that would meet your expectation. We are joined today by a faculty that I'm sure that will enhance the knowledge on the optimization of the care for MS and NMOSD or neurons optica and related disorder. Our speaker today will be Dr. Tarabolsi from Vancouver, Canada, Dr. Yasser Malik from Riyadh, and as well the moderation with us and one of the physicians is Dr. Amani Shahri. This webinar will be almost 1 hour, and we are hoping that that it would give you an update on the MS and NMO therapies, as well as the clinical consideration in the COVID-19 and the need for MS patients. Just to remind you that this program is accredited by the internationally by MOC Section 1 as defined by the Royal College of Physicians and Surgeons of Canada and approved by the Queen's University, and it's under the processing or under the accrediting process by the Saudi Commission for Health Specialty. I would like to just make sure that you are all welcome to address all the questions and comments using the question bottom, and we'll try to address as much as we can. If there is more items and what we could do, we'll definitely make consideration on the future webinars. And now I'll just go on and kick off the initial presentation, and this for Dr. Tarabolsi and Dr. Amani.
Hello, everyone. I'm Tony Trabolsi. Pleasure to be here. Well, I wish I could be there, but pleasure to be connecting with you virtually and to give you kind of an update of more of my own perspective on treatment of MS and NMOSD. I've been working in MS for over 20 years and NMO over 10 years, and I've been involved in a lot of different programs and clinical trials, and it's been very exciting to see the evolution of care in both diseases with modern therapies that have really, I think, improved and revolutionized not only the outcomes for patients, but how we think about the diseases themselves. These are our disclosures. And of course, there are always potential conflicts of interest. This is kindly sponsored by Roche, and I've done research work with Roche and many other pharmaceutical companies in the past years. So these are the learning objectives of the session, to develop treatment goals for patients with MS. And one thing I'm a big fan of is not only early disease-modifying therapy, but early high-efficacy disease-modifying therapy. So you may hear me repeat that point multiple times in the next 10 to 15 minutes. And of course, some updated knowledge about how to treat NMO. These are the outline of my own presentation, and we'll get right into it. It's really the treatment goals, what we're trying to achieve, and why early treatment is important for patients. Through this new term, the 5 Ds, I'll illustrate what that is near the end, and then why we monitor, how we monitor, and the reasons for switching, guidelines for switching, and what the future holds for MS treatment. And then down to NMO with some of the latest data on that. So these are, I think, our treatment goals in multiple sclerosis. And if we think of the 3 goals, we want to prevent new damage or prevent inflammation as a cause of damage. Ideally, prevent degeneration and allow patients to repair or enhance their repair mechanisms. We're probably made the greatest headways in terms of preventing new lesions, new relapses. That's where our treatments really stand out. We still have a ways to go in preventing degeneration, especially in the patients that have progressive MS. But some therapies seem to stand out more than others in terms of their potential to prevent degeneration when we use brain atrophy as a biomarker. And I think repair is a real phenomenon we see in clinical practice, and we're seeing more in clinical trials. As we turn off the inflammation, we're allowing natural repair mechanisms to occur. And we can enhance those natural repair mechanisms by the 5 Ds. So I just summarized here kind of the state of the art of current treatments available in many countries and many health authorities, and how the general MS community would classify them. You may or may not completely agree with putting them in certain bins, but this is generally how people will think of these medications as either first lines, which for the most part are the oral medications. I rarely use the interferons or glutamate anymore as a first line treatment. Ocrelizumab stands out in that group as being what I would call a high efficacy first line therapy. The second line treatments are listed below. Usually a patient has to be on a first line treatment for 6 months or a year and fail that treatment for breakthrough disease before escalating. There's many of us who feel higher efficacy is advantageous as early as possible in the disease course. And these are kind of the 4 drugs that are commonly put in that high efficacy bin. And then there's the oral cladribine and alemtuzumab, often called induction or immune reconstitution therapies. And bone marrow transplant would fit into that category as well. So part of the treatment recommendation with patients early on is in part based on our own personal philosophy of escalation from first line to second line versus high efficacy. So there's our own personal bias as physicians. And then there's also the patient needs. And with these variety of medications we really meet a lot of needs. And I won't go through them in any details, but these are certainly many of the things I will consider when discussing with the patient. And usually at the end of the interview, I will take that long list of drugs and say, these are my core recommendation and the 2 alternate recommendations for you to consider. And I might, depending on the patient, go through my explanation of why I made that recommendation. So part of the challenge we have in multiple sclerosis is how do we prognosticate an individual patient? There are some certain features that are bad prognostic factors, and a large burden of lesions on the MRI, the first baseline MRI, the presence of spinal cord lesions. Some recent data in the past couple of years indicates that lesions in the brainstem or lesions in the spinal cord are a very bad prognostic sign for future early disability, and certainly those patients I favor high efficacy therapy as early as possible. Multiple relapses in 1 or 2 years is also a bad prognostic feature. And some of these other aspects are what we can get the patient engaged to modify, treat their comorbidities, stopping smoking, taking some supplemental vitamin D. We usually recommend our patients take 3,000 to 4,000 international units of vitamin D a day. So I like this theme that time is brain. Gavin Giovannoni really came up with this. I think the stroke doctors tried to take it from us, but we own it. And so really the idea is not only to get patients diagnosed and start treatment as early as possible, but to monitor them for any evidence of safety, tolerability, and breakthrough disease so that we can escalate treatment if escalation is in their best interest. So I wanted to just take a couple slides to talk about monitoring. Our current strategy for monitoring patients is pretty simple. We do a clinical assessment every 6 to 12 months, depending on how active they are. Usually in the first year, I do it every 3 to 6 months. Very short visit just to make sure they're happy with the direction of care. So we do the clinical assessment as such. I think the future, there's a lot of other features we can capture. I won't go into that in any great detail. One thing I'm excited about is the concept of wearables, where a patient will record their own symptoms. This is a device that will track their walking, their activity, and that might go into machine learning algorithms to early predict patients that are starting to lose function without them being consciously aware of it. But I wanted to highlight, there are many switching guidelines that are all pretty similar. The idea is that if there is clear evidence of breakthrough disease, and it could either be, the typical ones would be a relapse or new MRI lesions, and there's different thresholds of new MRI lesions that qualify, or disability progression that one should consider escalation. And I think, which one is the ideal regime to follow? I don't think it matters. It's just the fact that we need to monitor our patients, have a threshold in mind, and escalate should a patient show signs of failure, because the sooner we intervene, the more likely they're going to have a better outcome. And this is an interesting concept this concept of therapeutic inertia in escalating treatment. So this was a nice study out of Spain, and been reproduced in Canada as well, where Spanish neurologists were given 20 case scenarios of patients who may or may not have been failing therapy, and to see how often did the neurologist identify the failure and recommend a change of treatment. And it's actually quite frightening that 2/3 of the neurologists did not recommend a change in treatment when a patient met the EMA criteria for escalation, European Medical Association criteria for escalation. So that's another, I guess, argument against escalation, because there's that risk of not escalating in a timely manner to a more efficacious treatment. And why does this happen? There can be patient-related factors. This is data from Diabetes World, but half the time it's a physician-related factor to escalate treatment when there's clear guideline indications to escalate. That's usually a failure to either identify the failure or to act on the failure is quite commonly the reason. And this is the cost to the patient of not escalating or not starting with high efficacy therapy. This is data from Europe. Each colored line represents a different European country. And what it's showing is that percent of people who are employed. So in orange shaded area, that's the general population age 25 to 54, and the majority are employed. But if you take the same age population of multiple sclerosis patients, even at a very low disability level, 2 to 3, when they're not even recognizably disabled to the average person, you can see that many of them, about half of them, are unemployed due to MS. So we really want to intervene before disability becomes obvious. And this is yet another data slide illustrating the importance of early treatment. This is time to a disability milestone relative to the time of starting treatment. So patients in purple started treatment within a year of diagnosis, and fewer of those became advanced in their EDSS score compared to those that had a 3-year delay in red. So now I'm going to, so I think I've made the argument about early treatment with any of the agents. Now the argument for early treatment with high efficacy. And this is the data from the OPERA study looking at progression independent of relapse activity. So on the left, you have the interferon patients. On the right, you have the ocrelizumab patients. And this is a more comprehensive marker of progression, not just a change in ESS, but also, or could be progression of time, 25-foot walk or normal peg test. And here you can see on the right that the ocrelizumab patients, while there is still some patients showing signs of progression, is proportionally lower than we see in interferon patients. Further evidence of high FC treatment. This is from the alemtuzumab studies, which I was also part of, and this is looking at brain atrophy, brain shrinkage, which is quite common. MS brains shrink 10 times faster than healthy controls. And what we're seeing with high FC therapy, just using alemtuzumab as an example, and they're the patients in blue, and interferon were the patients in black, then switched to alemtuzumab in orange, is that we're seeing fantastic stabilization of annualized brain atrophy rate with high efficacy therapy and repair, improvement. All patients have the capacity to get some improvement, even placebo patients, interferon patients in black, but it's really the patients on the higher efficacy therapies that seems to have the greatest chance of improvement, and that seems to increase over time. So I think if we can really nip the disease early, turn it off early with, again, big fan of high efficacy therapy early on, we give the patients a better opportunity to repair as well as being stable. So going back to the conclusion of the treatment, my current views on the treatment of MS, want to prevent inflammation, and so I think I made the argument for early treatment with any of the disease-modifying therapies, and recognizing people may be going along the pathway of escalation or high FC as early as possible, but the key is to start as early as possible. And I was making the argument why I believe high efficacy as early as possible helps prevent degeneration. We have a lot of compelling data across different drugs to suggest that. Another point I wanted to make is I find MS is most inflammatory in that first 10 years or so, and it does tend to cool off afterwards, and so you use high efficacy when it's at its potential worst. Part of my rationale. Here are the 5 Ds. To enhance repair, use early disease-modifying therapy to prevent damage, optimize diet, add vitamin D, encourage the patient to exercise, and encourage them not to smoke. And I think those 5 Ds might optimize long-term future for our MS patients. So I hope this MS section will stimulate the conversation coming up soon. Some of the things where we're going is whether or not, what time in a patient's life cycle should we stop therapies? As they get past 60, they're less likely to have relapses. Do they still need to be exposed to these medications? And where are we at with stopping progression? There's still a lot more work to go there, and I think the latest area of interest is with the BTK inhibitors as an emerging potential therapy, or even higher doses of ocrelizumab are being looked at in some trials as well. So we'll see in the next 5 years some important new data about how treatable is progression. So now, with the time remaining, I'm just checking my time. I'm going to have a few slides on the treatment of neuromyelitis optica, another area close to my heart. And often, these patients will come to us looking like multiple sclerosis, but the approach is very different in many ways. For example, when identifying and treating relapses in our multiple sclerosis population, we might not always give our patients steroids. We might wait to see is it getting worse or not. Whereas with NMO, I do advocate early and rapid steroids for relapses, and not to let it get better naturally. In terms of preventative therapy, it's rare in multiple sclerosis. In fact, we never use combination treatment. We don't use two DMTs to control an MS patient. We escalate them. In NMO, it's not uncommon that we need to use to add on a second therapy. And so knowing the safety of the two drugs is very important, especially because a lot of our patients have comorbidity, and we don't want to increase risk of infections or issues with the other diseases. And so I'll come to this in a little bit later, but for example, satralizumab is very excellent for combination therapy. And then there's the the choice of preventative treatment. Many of the MS drugs would be ineffective or aggravate NMO, with one or two exceptions. And so that early accurate diagnosis is really critical. And this slide just really illustrates the cost of NMO relapses. This is a retrospective study, close to 200 patients, and what you can see is as time goes on, the risk of death, EDSS of 10, is quite high in this population. And I'm hoping this is really historic data and that we can do a much better job. But the goal to doing a better job with this population is, again, treating relapses aggressively and getting patients on the best monotherapy or combination therapy as soon as possible. Prior to the recent clinical trials, a lot of the treatment recommendations for first line, second line, third line were based on case series and expert opinion. And often these still remain some of the first line treatments around the world. Part of that depends on getting access to the medications. However, we now have several clinical trials, high quality placebo-controlled studies. This is the satralizumab trials, which I was part of. Sakura Sky, Sakura Star. Sky was a combination trial, and that was using baseline therapy, which could have been azathioprine, mycophenolate, or oral steroids, were being used as monotherapy with placebo or in combination with satralizumab, a one-to-one randomization. And then the STAR was a monotherapy trial, so pure placebo versus satralizumab alone. And quite a wide age range, 12 to 74. So we have some data on safety and efficacy in adolescents as well as in elderly, both, and importantly, the monotherapy versus combination therapy. And looking at just the group that were aquaporin 4 positive, you can see quite high efficacy. The primary outcome was at week 48, and then the reddish color is the satralizumab group. On the left is a combination. On the right is the monotherapy trials, and very effective treatment. And importantly, the safety was excellent. There were no deaths, no serious infections, and there was no difference in safety with the combination compared to monotherapy. So great evidence from these two trials of efficacy and safety and the ability to do a combination therapy safely, which is often needed in NMO. These were the two other main clinical trials. And Eluzumab was an anti-CD19, so similar to anti-CD20 therapy, just taking out a few more immature B cells. And again, highly efficacious. There was one death in that study due to, I believe, a severe NMO relapse. And then eculizumab is a bit more intense treatment, an anti-complement treatment, requires intravenous every 2 weeks. Again, very efficacious. There was a death in that study due to infection. So I hope that gives you a bit of an overview of the newer treatments for NMO, and just to consider really early use of steroids for relapses, and also the early use of combination therapy if there's some breakthrough disease while on a monotherapy, and the considerations around safety around combination therapy. So with that, I hope I can close and leave for discussion later on. or discussion now?
During the presentation, none of the attendees put any questions in the chat section. So if anyone have any question, please feel free to ask so we can share it with the other rest.
Yes, I'll jump in. I do see there was a question, Dr. Trabulsi, what do you see as the major barriers to the early use of high efficacy DMT?
Oh, I thank you. I know local in Canada, amongst my colleagues, there's some of the hesitation. I guess the two hesitations really are a lack of experience using them. So I think if you've never used an infusion therapy before, there's often some mild reactions that patients have that some people overreact to and think might be allergic reaction. And so just getting used to using infusion therapies, once you've gotten comfortable with them, and then that's been one of the big barriers. The other philosophical barrier is some people feel there's a different safety profile with high efficacy therapy. But when you look at, for example, if you look at the opera study, ocrelizumab versus interferon, there was no difference in safety in terms of risk of infections, which is quite remarkable. So and the tolerability was so much better. So I don't think that's a strong argument. One of the other arguments, I guess, around, for example, ocrelizumab, with chronic use, you might get some immunoglobulin depletion. And so some people are worried about infections later on after 10, 20 years of exposure. My feeling around that is, how I balance that is I see that first 10 years of MS as being the most aggressive time of MS for the patient. And so using high efficacy for at least that first 5 to 10 years of the disease, putting them in a really good position, allowing them to get on with their lives, and then consider backing off if I'm seeing any safety issues in the future. But I've had patients on these drugs, on ocrelizumab, for example, for over 10 years because I was involved in the phase 2 clinical trials. And it's rare I've had to discontinue treatment on anyone. And most patients have fine immunoglobulin levels. And even those with dropping immunoglobulin levels, I'm not seeing issues. So I think some of those arguments for delaying high efficacy therapy are more theoretical as opposed to practical.
Thank you very much. A couple other questions here. A female patient with aggressive MS and remote history of Hodgkin lymphoma, which was treated and went into full remission. Which DMT would be contraindicated in view of the history of lymphoma?
So she was probably treated with a bone marrow transplant, I imagine. That would cure her MS if she was treated with that. Which would be contraindicated? Well, I'm not sure which would be contraindicated. She's still having active MS. Certainly something anti-CD20 therapy would be fine. Again, I don't tend to use interferons or tumor acetates. Those would be fine. Teriflunomide would be fine. I'd probably avoid Tecfidera and Gilenya or fingolimod, the SP1 inhibitors, I'd probably avoid. Natalizumab would probably be okay. Alemtuzumab would probably be okay as well.
Great, thank you. And we'll have another question, one more here. What about screening of MS in the primary care settings? Are there any guidelines to be used in this screening for consideration?
Oh, in the gosh, for MS, yeah. I think there's two different approaches for the primary care. A big part of that really depends on how quickly a patient can be referred to a neurologist for assessment. So if there is a long delay to get into a neurologist, I think doing MRI is probably the easiest screening test, prone to false positives. I guess the thing for primary care is that so many people have neurologic symptoms that they see their family doctor for. So not everyone necessarily needs an MRI. So I think probably the most cost effective is if those patients with neurologic concerns can see a neurologist in a timely manner. But if not, MRI is the next best thing. As long as the radiologists don't put on the report, looks like multiple sclerosis, or meets diagnostic criteria for multiple sclerosis, because that is really, the MRI can only be interpreted in the context of the symptoms. The MRI just picks up so much white stuff. 5% of the general population will have a few white spots that can be misinterpreted. Some great studies on misdiagnosis of MS.
Great, thank you very much. In the interest of time, we will we'll move on, and appreciate that very much. And if we have some time at the end, we can try and revisit some of the questions. Thank you.
Thank you.
Thank you. I think now we'll go with the second presentation. And Dr. Yasser, please go ahead.
Thanks, Prof. Mohammed, for the introduction. I'm Yasser Al-Malik. I'm one of the MS neurologists at King Abdulaziz Medical City here in Riyadh. In the next 20 minutes, I'll give you a quick update on the impact of COVID-19 on multiple sclerosis and the application of COVID-19 vaccines in people with MS on various disease-modifying therapies. These are our disclosures. So the learning objectives, by end of this webinar, we will review the COVID-19 impact on delivery of MS care here in Saudi Arabia, describe the severity of COVID-19 infections in people with MS, and review the current COVID-19 protections and vaccine recommendations in patients with multiple sclerosis. So if I may start with an interactive question. So what do you feel are the most significant issues experienced by your MS patients since the start of the pandemic? You may check more than one option, and we can give 1 minute. So you could vote now, please. So you have a variety of options, either access to the clinic, access to MS therapy, access to the COVID vaccine, psychological impact of the pandemic, loss of employment, family challenges, MS relapses, non-adherence, and finally the concerns over the safety of DMTs and risk of COVID-19. We have 30 more seconds. If we could project the result of the poll, please. Wow, so it's heavily distributed among a variety of options, but it seems that it's more about access to COVID-19 vaccine and MS therapy and access to a clinic, which I think is probably shared by most neurologists in the kingdom. So if we can close this, please. Now we'll move on to the next slide. Okay, so I'll present two cases just to exemplify some of the key challenges that our MS patient faced during the pandemic. So this is a 30-year-old man who's diagnosed with relapsing MS about 3 years ago. He has been working from home for the last year due to COVID-19 restrictions. His employer now wants him to team back in the office. However, the patient is quite worried that he's going to get COVID-19. He read that people with MS are at higher risk of negative COVID-19 outcomes. He also heard that people with MS, they don't respond well to the vaccines. The patient is the only wage earner in the home, and he must keep healthy all the time. And the second case is a young lady who has been called by the MS clinic as she hasn't come for her last 2 infusions of DMTs. When speaking to the neurology team, she mentioned that her aunt contracted the virus and was hospitalized and still experiencing significant health issues 9 months later. She has read also that her DMTs weaken her immune system and put her at higher risk of serious complications. She was also worried to come to the clinic and potentially exposed to the virus. She has, however, received the full 2 doses of mRNA vaccine, but also read that the vaccine might not be effective in reducing her risk of infection due to her therapy and MS. These 2 cases exemplify primarily 4 of the major challenges that MS patients faces. So the many patients with MS are worried of an increased risk of COVID-19 infection and its complications just by virtue of having MS. Many patients were self-isolating, especially early on during the pandemic, and not interacting with the healthcare services. Significant population of MS patients are worried of potential increased risk of COVID-19 complications due to their DMT. And there are also concerns shared by physicians and patients that MS therapies can decrease the response to COVID-19 vaccines. So I'll try to cover these four main challenges in my presentation. So first question, does MS impact COVID-19 outcomes? I think overall we've been increasingly reassured that people with MS are not at increased risk of contracting the virus or its complications just by virtue of having MS, and that there are no obvious increase in risk of complications with disease-modifying therapies, with the exception of anti-CD20 B-cell therapies that may increase risk of hospitalizations, at least based on the Italian and the COVI-MS registries. Here you see our local data in the kingdom in a project led by Dr. Fawzia Shamrani. The analysis included 70 MS patients in various regions, all of them with a positive PCR testing. 71% were female. The vast majority of those patients were on a disease-modifying therapies at the time of infection. The most commonly used DMTs are fingolimod and interferon beta, which constitutes more than 50% of our cohort. Overall, the vast majority of this cohort experienced no symptoms or mild symptoms. This is most likely related to the younger age of our patient population, with a mean age of 33, the female predominance and lower incidence of comorbidities. In our data, we did not find any association between negative COVID-19 outcomes with the MS duration or disability as measured by EDSS, and there is no association between DMT use at time of infection with COVID-19 complications. It's important to note, out of 70 MS patients, only 10 were admitted to the hospital. 5 of them were not on a disease-modifying therapies. 3 were on an anti-CD20 B-cell therapies, 1 on teriflunomide and 1 on fingolimod. Only 2 patients were intubated and admitted to the ICU, 1 patient on ocrelizumab, and the second patient was not on treatment. However, he received pulse therapy 2 months prior to presentation. This is another collaborative paper was published in March 2021, providing guidance for managing patients with MS during COVID-19 pandemic in Saudi Arabia. It's based on a literature search conducted in mid-July and mid-2020, including recommendations from International MS Organization. Basically here, there were specific questions were presented to an expert panel with a consensus rate predetermined as 75% agreement. Admittedly, there were very little data regarding COVID-19 and MS population at the time of the publication of this paper. So first thing, we addressed the COVID-19 effect on healthcare delivery. Personal experiences from the panel of experts indicated that major impact on MS management in Saudi Arabia were similar to other countries. Specifically, consultations have moved online or by phone visit, with only high-risk patients were seen for in-person consultations. Medications had to be delivered to patient home or through the drive-through pharmacies. The lab testing and monitoring were suspended or delayed for some patients. For example, patients on alemtuzumab, instead of having monthly monitoring in some centers, were spaced out every 3 months. Management of MS relapses for patients living in different regions away from their primary neurologists presented a particular challenge. Patient had to go to the ER for possible relapse or a pseudo-relapse. Also, difficulty communicating with health professionals that did not understand the difficulty of interrupting DMT supply, resulting in reactivation of the disease in some patients. Now, looking at the COVID-19 impact on MS patients, significant negative neuropsychological impact was noted. There is a local Saudi Arabian study reported about 50% of MS patients reporting anxiety about using their DMT during COVID-19 pandemic, and more than a third missing their hospital appointment. And this is primarily regarding the concerns for MS affecting the risk of COVID-19 or their DMT increasing the risk of complications. Unfortunately, some patients postponed their scheduled DMTs, resulting in a reactivation of their disease. The risk of acquiring infection with disease-modifying therapy is quite variable. One of the questions that was presented in the expert panel is to provide a risk category of perceived risk of infection for each individual disease-modifying therapy, 1 being the lowest perceived risk, and 4 being the highest perceived risk. And as you can see, the risk of acquiring infection was perceived highest with alemtuzumab, followed by ocrelizumab, cladribine, and so on. The interferon beta 1b was associated with lowest perceived risk of infection based on this expert opinion. The also consensus methodology was used to assist the recommendation for initiating DMTs in relapsing MS patients during pandemic, but in patients without active COVID-19 infection. And the panel was unanimous in that interferon beta, teriflunomide, natalizumab can be initiated, and a consensus supporting the initiation of dimethyl fumarate. With regard to continuing DMTs in relapsing MS patient without COVID-19 infection, so patient on treatment prior to the start of pandemic. So the panel was also unanimous about continuation of interferon beta, the teriflunomide, dimethyl fumarate, and natalizumab. There was also consensus supporting the continuation of fingolimod and cladribine. More than a half of the expert panel support the continuation of ocrelizumab, and the majority recommended to postpone follow-up infusion of alemtuzumab. Now, with regard to continuing DMTs in patients with active COVID-19 infection, interferon beta 1b was the only disease-modifying therapy with a consensus supporting its continuation. About a half of the experts would continue dimethyl fumarate, and a third would continue teriflunomide, natalizumab, and S1P modulators. Again, this is an expert's opinion. It doesn't give you the right or wrong answer. It just gives you what the experts recommend. Now, with regard to COVID-19 vaccine considerations for patients with MS, it's recommended to follow the general vaccine guidance, ideally to vaccinate prior to start the DMT, and then giving 4 to 6 weeks window to allow the vaccine to develop a full effect. It's generally recommended to avoid live-attenuated vaccine. It's important to emphasize that the COVID-19 vaccines available in the kingdom are non-live vaccines. So this includes the mRNA vaccine, the Pfizer, BioNTech, and Moderna, as well as the AstraZeneca, and therefore they are not contraindicated for patients with MS. The question is not about the safety of these vaccines, it's more about the efficacy and the optimal timing of the vaccination. That leads me to the next slide. So we assess the expert's opinion about the likely impact of DMT on the efficacy of COVID-19 vaccine. And as you could see here, the interferon beta, the teriflunomide, natalizumab, and dimethyl fumarate, the vaccine response will likely or probably be intact. On the other hand, for cladribine tablet, anti-CD20 B-cell therapy, and alemtuzumab, the experts' consensus that the vaccine response is possibly diminished and would be mostly diminished with S1P modulator. And this is based on extrapolating data from seasonal flu vaccine and tetanus toxoid that was reported prior to the pandemic. And I think we have, since the publication, we have more accumulating data for SARS-CoV-2 vaccine supporting the expert consensus. Now, with regard to the recommendation of withdrawal of DMT and immunization, or the washout period, for the platform therapies, interferon, teriflunomide, dimethyl fumarate, and for natalizumab, no washout period required, and the patient can receive the vaccine immediately. For cladribine tablet, it's recommended to wait until lymphocytes have recovered. And on average, the lymphocytes reach the lower limit of normal during year one of treatment, recover to this level by week 36 of the year 2 course of treatment. Same thing for alemtuzumab, which is also an IRT that's recommended to wait until lymphocytes count have recovered, which on average it takes about 6 months since the last treatment cycle. For S1P modulators, the recommendation is to vaccinate without washout period, knowing that the vaccine response will likely be diminished. However, the risk of stopping the fingolimod or siponimod with a rebound phenomena outweigh any potential benefit. For anti-CD20 B cell therapy, the consensus recommendation based on this expert paper is to wait for 4 months since the last infusion. This is a recent systematic review that was published just a couple of months ago. It included data from more than 4,000 MS patients. And the bottom line, it confirms what we already know. MS does not lead to higher risk of acquiring the virus or its complication. The risk of severe COVID-19 is similar to general population, i.e. advanced age, comorbidities, and higher disability. Most disease-modifying therapy have negligible influence on the COVID-19 instance and outcome, with the exception of DMTs causing severe lymphopenia and hypogammaglobulinemia like anti-CD20 B cell therapy, which may increase risk of negative COVID-19 outcome. With regard to COVID vaccine, blunted immune response have been reported for many DMTs. There is the Israeli study that looked at extremely low efficacy for fingolimod, about 3% humoral immune response, or ocrelizumab, about 30%. So I think this is moving forward. We might need to consider booster vaccination for those patients on those DMTs. And there is no evidence to suggest increased risk of relapse following the COVID-19 vaccination. With regard to vaccination failure, I think there's only one case report indicating vaccination failure with anti-CD20 B cell therapy in MS patient, and a second patient on rituximab for a different indication other than MS. Again, being vigilant for patients in those treatment and optimizing the vaccination timing can help to prevent vaccination failure. I apologize for the busy slide. I'll walk you through this quickly. This is a summary recommendation from this systematic review. It's basically indicated or confirmed what we discussed earlier in the consensus paper. So platform injectables, the teriflunomide and dimethyl fumarate will likely not impact the vaccine response. And the recommendation ideally to vaccinate prior to starting the DMT. However, if the patient is maintained on those DMTs, is to vaccinate without washout period. For S1P modulators, there is, I think, enough data to suggest that fingolimod would blunt the immune response to different vaccines, include COVID-19. However, it's recommended to offer the vaccine without washout period. For cladribine tablets, there are no specific studies, but MS patients under cladribine have mounted an adequate immune response to flu vaccine after 4 weeks of vaccination in the Magnify MS study. And COVID-19 vaccine 3 months after second cycle promoted also an adequate immune response. And therefore, their recommendation is to allow 3 months gap after the treatment cycle for the vaccination or until the recovery of lymphocyte count. For natalizumab, it's possibly there is no impact on the vaccine response. And I was mentioned earlier to vaccinate before you start, but if the patient is maintained on natalizumab, it's just go ahead and offer the vaccine. For anti-CD20 B cell therapy, there is data to suggest both from Beloshi study published in 2020 and also case reports for SARS-CoV-2 vaccine that humoral immune response is blunted. The recommendation from this paper is to offer the vaccine 3 months after the last infusion cycle, and then to wait for at least 4 to 6 weeks after completing the vaccine. For ofatumumab, vaccination to be delivered toward the end of the monthly cycle, and then the next 2 ofatumumab doses to be skipped. For alemtuzumab, the recommendation from this review article is similar, is to wait 6 months after the last treatment cycle or until the lymphocyte has been reconstituted. So I'll summarize the key learning point. So we've discussed that the COVID-19 pandemic has caused significant impact on the delivery of MS care here in the Kingdom, quite similar to other countries in the world. MS patients, they don't seem to be at higher risk of severe COVID-19 complications, but similar to general population, the risk is higher if they have older age, comorbidities, and higher disability. Clinicians have and will continue to adapt the delivery of MS care to meet the changing prevalence of COVID-19 in the community. We have to be vigilant about some DMTs that may impact the response to COVID-19 vaccines, and maybe adjustment of the timing and offering booster vaccination at some point in the future may be important. And the current data does not support an increased risk of relapse when immunized with COVID-19 vaccine. That's all I have. Thank you very much for your attention.
I think you made a good summary for the majority of the point. One thing to really just stress on that we have been truly lucky in Saudi Arabia with the way that COVID-19 was managed, availability of vaccine, and the way things structured. I think the full closure for our patient to be virtual was almost about two to 3 months. After that, everything was open, and that has been as well was dealt on with a very way of really good way to enhance the delivery of medication. I think we have some issues only with injectable, which did happen with some patients slight delay, but overall, I think even looking into the number, we see that there was a good recovery. We have a few questions, and I think two of them you have already mentioned a little bit, but maybe you need to expand on those. We hear a lot of the booster dosing. We know that Saudi Arabia now is doing a booster for the third dose for people above 60 or people on dialysis or transplant. They did not come to our patient with MS yet. Which patient or what's your thought about the booster dose, and if we have if there is anything to go from the MS chapter, what are our recommendations? Which patient should be pushed to receive a booster dose?
A great question, Prof. Muhammad. I think it requires careful thought and brainstorming, but generally I would think that people on anti-CD20 B-cell therapies, they're the one who might benefit from booster vaccination. Patient on fingolimod or S1P modulators, giving that accumulating data to suggest that the humoral immune response is diminished. I'm not sure if we have enough data for cladribine or alemtuzumab to make and I don't think, especially for alemtuzumab, I don't think we have tons of patients in those on that therapy. But it requires, I think, a consensus discussion and to come, but definitely for anti-CD20 B-cell therapy, I think, and fingolimod for sure. And I started talking to my patient, preparing them that this is something we might need to consider in the future until we get the, I think, the green light from the Ministry of Health, if we have enough vaccine supplies to offer it for our patients.
What about Tecfidera? Would you include that with the booster dose as well?
I don't think I've read data that Tecfidera is or dimethyl fumarate is affecting the humoral immune response to vaccine. I don't know if you have, and I didn't see any publication on vaccination failure on patients on dimethyl fumarate. But I guess if those patients having significant lymphopenia on dimethyl fumarate, that's something that might be considered also.
Thank you. We have another question, which is really the way of handling the patient who refuse to receive the COVID-19 vaccine. And we have few of those patients. How you'd handle that? How do you handle that with your patient?
Well, I think you need to spend a long time discussing the pros and cons of getting the COVID vaccine or, just continuing their life without vaccination. I think we have tons of data to suggest that people who get the COVID-19 vaccine, they have protection against severe COVID-19 outcome. I'm usually more careful with those patients who have significant disability or have comorbidity that put them at higher risk of severe COVID-19. But ultimately, it's the patient choice. And obviously, you can't force or impact that they have to take it. Like, and it's really tough. I'm usually for those patients who are not convinced, I book an earlier follow-up, maybe readdress this with them, presenting more information. But it's some people they made their mind and some.
Yes, the new regulation now that came out on the 10th of October, people who are not vaccinated with 2 doses, they are not allowed to travel with airlines. They are not able to get into governmental anything with the impact on public health.
Right.
Many of our patients, they require or they ask about a letter that they cannot use vaccine. Would you give that letter or not? Would you give your patient their choice not to use it? It's their choice not to get vaccine. But would you support them? But with their MS, okay. I think the message which we need to talk that it's a but there are regulations in the country that if they don't really follow it, they have to deal with their choices. But I don't think as a healthcare provider or caring for MS patient, we should really excuse them from getting the vaccine. I got a question here. I got two questions, and maybe you should deal with them quickly. One is after MS patients are targeted, are they targeted with their dose? I think we answered that. And then the one question, which is, you mentioned in your talk that anxiety and some stress on the patient from being high, although the data does not support that, but being at high risk of COVID-19. How do you deal with your patients? How can you reassure them? If you give us 20 seconds, 30 seconds, just what are the main messages for the patients about?
Yeah, I guess in generally speaking, the vast majority of MS patients are younger patients. They have no significant comorbidities, and therefore they are not at higher risk of complications. For most of DMTs, the efficacy of vaccine is not affected. The only one that are on higher efficacy DMT, some of the higher efficacy DMTs, that you need to optimize the timing of the vaccine and then having the booster vaccination, that would enhance their protection. In addition to enforcing, I think, the protection, using the mask, the social distancing, that's important even if they receive the vaccine, to lower the risk of acquiring the infection. I think that's my message to my patients.
Thank you very much. I think for the sake of time, we have two more questions that I think one will answer directly just by emailing the patient, and the other one is not related to MS. And I think we should just be in this webinar, we are focusing on MS patient. I'd like to thank all our speaker and panelists for their excellent contribution. I'd like to thank as well you, the attendee, who have been a great audience, and we get a good question to really discuss. And I'd like to thank Ministry of Health for their support, BriefMD, as well as Roche for their sponsorship. Thank you all. I think we are good with time, and we're 1 minute above the time. But thank you.